Hello and welcome to EAO's YouTube channel for a brand new Just Ask Live session. My name is Hayley Edmonds and I am honoured to be your host for today's interactive virtual appointment connecting professionals from all around the world for a live chat with experts in implant dentistry. This is an interactive session, as I said, so if you do have any questions for our expert today, please don't hesitate in asking them on the live chat. In fact, let's kick this off by asking and finding out who you are and where you're connecting from around the world today. We're really keen to find out who and where you're connected from. We've got one already. Hello, Rida Mubarak from Tunisia has just tuned in. Pascal Valentini says, hi, Blackie. Of course, he knows who our guest is today. This gentleman obviously needs no introduction. It is, of course, connected from South Africa, Dr. Louwrens Swart, a renowned maxillofacial and oral surgeon, specializing in complex cases and aesthetic dental implant reconstruction. Also, the South African ambassador for EAO. So firstly, welcome. How are you doing?
Hi, Hayley. Thank you very much. I'm very honored to be asked to spend this time with you. And I'm really looking forward to a nice hour of just sharing on a very informal basis some information that I've gleaned over the years on dentoalveolar trauma.
Absolutely. We can't wait to really find out more. And as you said, it is a Just Ask session. It's an exchange. We're going to make it as kind of chatty and of course, informative as possible. And that's where everyone that's tuned in, of course, is going to play your role in asking any questions for today's expert. I'm seeing there are people tuned in, Dr. Esma from Turkey, Mario Vanelli from Italy, Dr. Orde from Bahrain. It's so great. Thank you all for tuning in. Croatia even. This is a real global event going on here, which is great to see. So as you did touch on, of course, Dr. Swart, aka Blackie, to, as you said, to your friends, and of course, a lot of your fellow professionals know you as Blackie as well. So the subject of today's live is dentoalveolar trauma, immediate and delayed implant challenges. So we will just kind of to touch on briefly, what you will be discussing today. Can you maybe just give a short definition of what you mean by that?
That trauma management is difficult to define well, or it is difficult to find well-documented cases, because if you are really interested in your patient and look after their best interest, it's not your first aim to grab the camera and take images, because those first minutes are crucial. So I'm going to spend a little bit of time on the science of that first immediacy, what is needed, and then the different management in different age groups. I'll first start off with an older age group, an adult with uncomplicated fractures, and then I'll take it into more detail, into more complex fractures. And then as the science picked up with us in our daily treatment plans, how it influenced our treatment. And then I will end off with a case of a temporary restoration being replaced now with the latest scientific evidence and what amazing results we can achieve.
As you did say, of course, trauma management is in constant evolution, and dental literature is being constantly published with scientific backup, and you're going to kind of go as far back as to 2006 today. But I mean, how would you say the initial management has changed over the past 10 years?
The initial treatment where we were taught at university on a long stabilization of the teeth and the dentoalveolar fractures has really gone by and is not so important anymore. The influence now is to look at the periodontal ligament And if you can keep that alive, and if you have trauma in pediatric patients, to try and re-establish the vascularization of the tooth itself. Because if you can maintain the vitality of the periodontal ligament and you can maintain the vitality of the tooth, you can get alveolar growth as per normal and thus the best aesthesis that you possibly can. And now, if you cannot, you must make that decision. How you're going to manage this case for their lifespan in that very first few minutes that you see this patient. Because if you've practiced the correct principles already in the first 15 minutes, you are going to save that patient a lot of psychological problems and also ongoing financial problems, as been reported in papers like by Porritt et al., where they studied the impact on children living with a traumatic loss of dentoalveolar components.
And as you say, there's so much depends on the initial, when the patient comes in, the very first meeting with the patient, the final treatment should be formulated and the initial treatment should be carried out with, of course, this in mind.
Yes, absolutely. The triage of trauma is the most important. That is defining which is life-threatening problems, make sure that you don't miss any underlying trauma problems like, for instance, a neck injury, a skull base fracture, all of that, because a patient might arrive at your practice with the only concern being a tooth that fractured, and then there might be underlying bigger problems. So if the person has not been evaluated by a trauma surgeon, you must be able to at least identify the problem and refer them to somebody else.
So Blackie, I do know you do have a lot of examples of literature in your presentation. Maybe you want to kind of start by explaining some references that you'd like to address today.
Okay, so the thing that started off or started me defining this and working out the lecture is the International of Dental Traumatology. When at first De Angelis et al. In 2012 started defining the rules for the management of trauma, they were more concerned with the root itself and the fracture of the alveolus. And that was how I was taught as well. But in 2020, this was reviewed by Ford et al. And this is absolutely a fantastic paper. It's one of the best papers that I've seen in a long time. And they also state that this must be seen as the state of the art on dental traumatology at this stage in 2020. The best evidence and practice based. And they concur that avulsion of a tooth is the most severe injury, and that occurs in 0.5 to 16% of all dental injuries. And the prognosis is dependent on immediate management, and that comes to the periodontal ligament. So if you then see a patient with a tooth that's avulsed, one must try not to engage the periodontal ligament. You must rinse it off with a physiological medium and put it back, and preferably as quick as possible. And less attention is put on the absolute sterility of that tooth going back rather than the time that it is spent outside of the mouth. So if you take the periodontal ligament and in about 15 minutes, you can keep it viable. But between 15 and 60 minutes, it is compromised the periodontal ligament of the tooth, and you can still save a tooth, and it might go either way. So the first 15 minutes is absolutely essential. And then above 60 minutes, you must know that you are going to have a compromised situation, and most probably an ankylosed tooth, as a case will show you, which I will demonstrate in a moment or two. So the treatment is, as we know, is physiological irrigation. Try to use local without vasoconstriction, replant as soon as possible. And then the stabilization is now only recommended as 2 weeks, with not a rigid fixation, but a little bit mobile in the flexibility of the wire. If it is in occlusion, like in primary mixed dentition, then another 2 weeks can be recommended, but not the 6 weeks or 3 months of the case that I will be showing thereafter. If these criteria are met, you can get revascularization, and never do an endo unless you have got signs of necrosis, and that's in the pediatric group. Obviously, in adult group, it would differ a little bit. In our extended times, when there's more than 60 minutes, we know there's a poor prognosis. The periodontal ligament is most probably necrotic, and you can expect ankylosis at best. And with ankylosis, you get the diminished growth as well as related resorption to the roots. That can be commonly expected. And always replant even a portion of the tooth if you are unsure in the beginning, because it is for the aesthetics and the function that you can put it back, because this is going to maintain alveolar contour width and height.
But Blackie,
now,
what about the risks of infection by doing that? Yes,
the risks of infection, we are luckily in the face, there's a lot of blood supply. If you compare that, say, with a limb, and with that big amount of blood supply that we have, or good blood supply that we have, infection risk is really low if you combine that with an antibiotic regimen. Mm-hmm. And that we know. So yes, the less blood supply you have, thus in an avulsive type of bone and soft tissue damage, you are going to get worse results, and the chances of infection can be higher.
I see.
Yes, so you're absolutely correct in that aspect. Our only criteria for keeping a tooth or replacing it immediately, now I must continue with my previous slide where I said always replace a tooth. But if we see that tooth is really a poor prognosis, and we have the opportunity to place an implant, say within the first 24, 48 hours, then we do that. And the only criteria that we use to save a tooth or not is if there is a ferrule available, like described in this article. And that is 1.5 to 2 millimeters of sound tooth structure above the ferrule margin. And this is resistant against biomechanical failure of that tooth. And as you can see, what I said in 2006, I published this case where now I cringe when I look at it, because we did not have evidence, scientific clear evidence in 2006 how to manage these cases. You can see that I did an open flap technique. I placed the implant, luckily, in the correct position, but I had thick alveolar mucosa. And because I had those criteria to work from, I could achieve a very good result with a single tooth that was lost due to trauma. But scientific evidence like the studies of Boozer and Chen shows us that it was not viable in the long term, because if you do not do hard and soft tissue grafting at this stage, you do not get consistent and predictable results. So that is where we started. So to share a case with you, this is a fellow dentist, professional adult, that had an interpersonal conflict, and he arrived the following morning still with his orthodontic brace intact at my office, and he was very embarrassed to have lost his front 2 teeth. And there was a need for immediacy. And in that case, obviously I did not take a lot of pictures, but what I can show you is that I immediately removed the roots, immediately placed 2 implants, and we immediately loaded these cases. So the provisional after 12 weeks was satisfactory. And you must remember that we still used cast abutments in 2007. One thing that technology has proved us far beyond where we are now, or whether products we have available now, is that we also cemented these restorations. Now I would never do that. I would always go for a screw retained restoration, as that science has shown us that's the way to go. So I'm first taking you along the path of learning of how I got to my results that the results that I achieve now. But after an 8-year follow-up, even with cemented restorations, this, I think, is still satisfactory for a patient that lost 2 teeth in a traumatic way. And this is way back in 2006 where it was done. So if we carry on with this next patient, he was a male student. He was first seen by his primary dentist, who did the correct treatment by replacing the teeth on a splint. There was obviously a problem. And here you can see what I saw first when I saw him was this nick in the frenulum. And that is the cause of problems in the long term. So we took a 3-dimensional, and this teeth were beyond restoration. And we also had a dentoalveolar bony fracture. So the removal of the teeth were done atraumatically, and the pupil was carefully sutured together, as well as a frenectomy was done to achieve a good soft tissue profile to these implants. And here you can see the essence of what science taught us is that you need to augment the soft tissue as well as the hard tissue if you want to achieve 3-dimensional stable emergence profiles of your soft tissue.
This case he's a young adult, but when you say young adult, what age are we specifically talking? Because for this kind of interventions, of course, there is sometimes a waiting period for the buccal area for your body to grow. Yes. So what age are we talking here?
In our experience, we rather go for a later age. I prefer to do this at 21. So if the patient is 21 and above, I have no reservations to immediately replace those broken roots with permanent implants. But we know that sometimes you are in a very difficult situation, and once you can prove that the patient is fully grown, and you can determine that by x-raying all of the growth plates, you can sometimes place the implants a little earlier, but in our opinion, we seem to have changed more and more to wait until 21, because as reported in the literature, the problem that you get is as the patient grows further, you get infra-occlusion of these implants, and the teeth grow past it, and also a little bit 3D volume to the anterior of the implants. And at the end, the aesthetic result is compromised. So in our case, we now, the one thing that I've learned along the way is to have patience. And if you select your cases carefully, you can get very good results.
But just one thing, Blackie, with regards to, you did mention the fact that this patient had actually gone to see someone before. I mean, presuming you're kind of then not, you're coming off the back of you're having to deal with something that's already been put into action. Do you know what I mean? You've already, with a process that's already been commenced. How hard is it sometimes to deal with that, with dealing with the consequences of another dentist's decision? And are they always systematically the good ones that have been taken?
This case, the dentist did exactly the right thing. He did not go and suture the wounds closed, nor did he try to attempt to take the roots out himself. He supported the soft tissue with the remainder of the roots. So according to that scientific article that I showed you, he did exactly the right thing. So kudos to him, congratulations. He did the right steps, and he knew the literature, and he knew the problems that can occur, and he referred the patient as quick as possible. So that initial 15 minutes, he used correctly. In this case, the teeth could not be saved. He recognized that immediately, and then splintered the soft tissue so that it could not contract as soon as possible, and then referred the patient to me to be operated within 24 to 48 hours. In cases like this, you have to open your book a little bit and see them as emergencies and treat them accordingly.
And this is why, going back to what you were saying in the beginning, the literature that came out in 2020 specifically was so groundbreaking, because it's really set very kind of concrete guidelines for professionals to be able to follow.
Yeah, and a lot of good practitioners knew that from their practices and handling. It was just elegantly put together with this article in 2020, giving it absolute scientific base. But I think a lot of professionals with a good training and a good work aesthetics knew that by heart.
Of course. Right.
Yeah. So if I can continue to this case, you can see that the three-dimensional stability of that soft tissue is just superior, because initial soft tissue grafting was done. And this is stable forever because it's own tissue. It is it's according to the principles of immediate placement and loading. Obviously, I have no experience of leaving a part of the root, the PET techniques, partial extraction therapies. But I suppose if the case is appropriate for that, it is a technique that can be used.
We do have a question from Pascal Valentini. Can we expect any benefits for adults in using socket shield techniques in case of trauma?
That's just what I answered, Pascal. Good night to you, Pascal. It's good to hear from you. Yes, I think, as I said, I do not have experience with the partial extraction technique, but it is most definitely a technique that is now, after the last Just Ask session that was given on the subject, I think it is definitely something that can work. But I myself do not have any experience, but I think there's enough scientific literature to support it at this stage.
Fantastic.
So to continue, so the final restoration after we've had this beautiful soft tissue restoration, you can see that zirconia was done, zirconia being extremely friendly to the soft tissues. And this is the long-term 10-year result with an extremely stable soft tissue. And unfortunately, it hasn't got a high lifeline, but that doesn't mean you mustn't give everything you can to help the patient. Then in our next case, this is the pediatric group. So this is a male, 14 years old, with traumatic injury. He was seen within 30 minutes at the dental office. The 1-1 was avulsed but held by gingival tissue on the buccal plate. And there was laceration of the gingival tissues, and the 1-1 and 2-1 were fractured apically. Now, this is just what we've been talking about, the science, how this affects our daily lives. So this patient, and this is the dealing with the trauma, that the article that I referred to in the beginning by Porret et al., how it carries an enormous psychological and economic burden for the rest of this patient's life. But he was seen, and according to the dentist notes, because luckily I got hold of the dentist notes, then this case was actually presented somewhere. He did cupious irrigation with chlorhexidine. He removed the 1-1 and did an endo extraorally, and then replanted the 1-1 compared to its mate adjacent. Now, this is sort of like a double-blinded controlled study. What happens? Because the one central tooth were done, absolutely everything was done wrong according to the article in 2020 by Fowd, and on the other central was done absolutely correct. So let's follow this and see if there is validity to the science. So follow-up evaluation, eventually the 1-1 was extracted after 6 months because of infection. So at 15, this is what he looked like, and you can already see that there was a defect on where the central tooth was removed. Because of his age, the orthodontist decided not to go ahead with any treatment at this stage, because we wanted at the end of treatment to place an implant in the correct position without redoing orthodontics. So the patient then returned to us at 21 years. So the 1-1 was absent, the 2-1 had an apical fracture, and the 1-2 and 2-2 had the two laterals had altered eruption and possibly ankylosis. And here you can see what the two roots look like. And that's why I say it's like a double-blinded controlled study, because they look very much the same to me when the first X-ray was taken. But I think this is done when you want to overtreat a patient. And this is old school, doing the root canal treatment outside of the mouth and then replanting it. Because you can see that the 2-1, which was the control, which was just splintered, had minimal apical bone support, and there was remnants of an apex still visible. So there was an open pulp chamber which re-established vascularization, because you could see in the previous pictures that tooth did not discolor. So it did, even with a half a root, it re-established vascularization. I still think it achieved ankylosis, because the splintage period afterwards were rigid and too long. It was splintered for 4 months. So, and yes, we know that in future it would most probably need treatment, but this is already 7 years later. So we saved 7 years, and 7 years of scientific knowledge. If we can save another 5 years, wonderful, because then it can only be replaced by a single implant. So definitely no treatment. And this is the case of how, if a tooth is lost traumatically, what happens to the alveolus. So you can see here at 14 years, there's a wide alveolus and perfectly acceptable to a implant. But if you look at 21, you can see that the bone is just in the wrong place. It had atrophied from the buccal and also a little bit in the vertical. And there was inadequate bone for implant reconstruction thus at 21. And if you looked at the picture pre-orthodontics and post-orthodontics, you can realize that there's a problem, because the angulations of all the anterior teeth that was involved in the trauma did not move at all. So although some growth had appeared and the premaxilla grew in a vertical and horizontal position, those teeth could not be uprighted by orthodontics because they were ankylosed. And here you can see what it looked like at that stage. And I then did an autogenous bone graft from the mandible with a single screw fixation, left it for 3 months healing. So the challenges that you have in this case is atrophied or ankylosed bone and scarred soft tissue and abnormal dentoalveolar growth. And here you can see, obviously, the new way now is to do digital planning. And luckily, with a new digital technique, even a template can be made with orthodontic braces in position, which was absolutely not possible with elastomeric impressions. And the implant was placed at the correct depth. And here you can see the problem of that angled lateral tooth, because that, from my experience, is extremely difficult to reconstruct with soft tissue to get a pupil, because it is easily retracted. And once it's retracted, to restore the pupil is very, very challenging. And at that same stage, a soft tissue graft was done, a connective tissue graft was done. And here you can see the initial healing. So a very good healing with a soft tissue in position, but then on the right-hand side, you can see there's an abnormality. And the soft tissue had migrated, although I had fixed it completely in position in the coronal part. And the problem was, the patient is a post-professional cyclist, and he was a student. And whilst he went for his morning ride, he was drinking from a bottle. And remember that that first Pontic was only fixed on the orthodontic brace. And as he pushed this bottle into his mouth, it made a 180 turn. And that tumbled that soft tissue apically. Now, what was I felt with all the scar tissue in that area, I still did not want to go back into that area, do a big flap and reposition the soft tissue. So I did a local soft tissue graft, and this is our result with a temporary restoration after the soft tissue grafting. And you can see that even though the majority of the soft tissue is apically, it still gives us a fairly good result. Remember, we are not talking about an ideal situation here, because those anterior teeth are ankylosed. So they cannot move, and the soft tissue, changing that around it is extremely challenging, because you're working with scar tissue and bone that has also been fractured and healed.
So in retrospect, going back to when he was 14 years old, how would things have been, how would you have managed things differently? Because it was taken out because of infection. So how could things, with all the knowledge that we have now, have been done when he was 14 years old differently?
Absolutely. If we go back to the article, then I would have, the tooth, although avulsed, it came out, it was still attached to soft tissue. So the dentist then removed that blood supply to the tooth and bone, took it out, touched the periodontal ligament, obviously, to do a root canal treatment, an extended time, we can think at least an hour before it was replaced. And he did not use a physiological solution. So he did not use a physiological solution. It was splintered for an extended time for 4 months. So I think if that initial 15 minutes had been used with the current knowledge and current scientific evidence, we would have had a situation where infection could have occurred. But I think we could have had a better aesthetic result than we had now, as in this case. But that is easy to say when you look with 2020 hindsight. If you are in that situation and you had that knowledge at that time, then it was the most appropriate treatment. But now looking back, I'm not criticizing anybody, I'm learning with them. Absolutely. It's like the case that you asked, but why the dentist put it back and then referred, was that the correct way or not? And I said, yes, it was absolutely. So we're having two cases where we can see how the science that was published in this 2022 article is absolutely relevant. And that's why that article absolutely stands out for me. Okay. So to continue with the case, when the definitive restoration was done, you can see that the final result is very satisfactory, and the bony osseointegration around the implants are also good, as you can see in the lower right. And now the patient had emigrated to England, and unfortunately I haven't seen him. So a 4-year post-op result, and you can actually see that the soft tissue around the implant is almost better for me than those of the adjacent teeth with the ankylosis. And I think that is because this is ankylosed and the graft on the implant is a autogenous graft. Although I had to do a bit of jiggling and a local transposition flap rather than a distant flap when he had the cycling accident whilst the implant was healed. Luckily, the implant was not lost and the integration is still good.
We have a question from Dr. Ode from Kingdom of Bahrain. Is it recommended in the literature to wait 18 months after trauma? And if implant done immediately after trauma will end with coronal bone reabsorption?
With coronal bone absorption, is that the question?
Is it recommended in the literature to wait 18 months after trauma? And if the implant is done immediately after trauma, will end with coronal bone reabsorption?
That obviously we've got to look at the literature, and then we have the decision to make at the age of the patient. So 21 years and above, if you use your scientific literature as for immediate replacement of a tooth by an implant, thus bone augmentation and soft tissue grafting, you can expect good results. I do not agree with the 18 months of waiting because I would wait a maximum of 3 months and then do bone augmentation immediately. So if there's a bone fracture, bone physiology is always the same. It takes 6 weeks for a bone to form, to heal, like in any other bone. So from the blood clot to the procallus to the callus to formation, that takes 6 weeks, and another 6 weeks to remodel. Then there is long-term remodeling, as you can expect if you wait 18 months, because of the bundle bone and the alveolus that becomes atrophied because there's not a tooth with a periodontal ligament in the alveolar bone. Right. So if you are going to wait 18 months, I think it's more a remodeling that you are going to get. And yes, the remodeling would most probably stop after 18 months, and then you can do a predictable implant as well. But the science does not favor that if one looks at trauma and bone healing after the traumatic event.
Okay.
So my take-home message after that is the depth of placement is very important. Soft tissue management is the ultimate. And I always say, the more you cut, the worse your results become. And allow time for tissues to mature before you go on to your next step. Angulation of neighboring teeth can be a very big red light, which must be carefully treated and managed with due care. And definitive trauma surgery is challenging. Not all results are the ideal, and sometimes one's got to accept that the solution that you have is most probably the best you're going to have. Then blunt trauma and the delayed type of treatment, this is like 18 months later. You can see a case where this young man had severe bone loss after blunt trauma and a dentoalveolar fracture. In this case, we had to wait a number of years, and this is the type of atrophy and reconstruction that you can find. There's absolutely very little bone left. Mm. And the preferred is to have a fixed, his preference was to have a fixed restoration with a minimum amount of surgeries. So in this case, you can see this is him beforehand with the partial denture in position, and you can realize the deficiency in an anterior-posterior relationship in this case. So what we did in surgery was to do a ridge split technique, because there was enough alveolar ridge to split. And if you split the ridge really up to the nasal floor, you can get quite an advantage from that additional bone, as you can see in this photograph. What I like to do in a case like this is to place my implants, if I can place it in the ideal position, so that it supports my buccally fractured bone. And here you can see the implants in position, and with the amount of alveolar bone that you split it as the base of your additional bone and soft tissue grafting. So that must be done additionally on top of, and the splitted ridge only gives you that extra support of vitality to this soft tissue. And here you can see the final result, and this is where the alveolar ridge incision was, and you can see where the markers for the implants are. And if the pre and post of the same patient, and you can see that the definitive fixed prosthesis was satisfactory for the situation that we were in. And the three-dimensional alveolus is also good. But that is not because of the ridge split alone. It is because of the bone and the soft tissue grafting that was accommodated and done at the same time of the implant placement, being most important.
What about the usage of aid or the aid of technology in accurate placements? I mean, how dependent are you on that? Is it?
Yes, it's very important, and it cannot be underlined that that is the most accurate way that you can do the planning. In that case, it was still an analog template that was used, and I could, on the 3D planning, I could envisage and plan so that the apical third of the implant was embedded in sound bone. And therefore, in the coronal part, I could augment the autogenous bone to quite a degree and support the soft tissue to have a long-term stable effect. Then we get to a patient with penetrating blunt trauma, and this is already a case from 2001. He had severe loss, or he was in a motor bike accident. Yeah, where he was taken off his motorcycle, and a severe loss of bone and soft tissue. And the case was only brought to me for a second opinion after previous treatment with bone augmentation and implants was unsuccessful. So there was severe loss of hard and soft tissue and unsuccessful bone reconstruction. And here you can see the images pre-op, 6 months later after the bone augmentation, and then the placement of the implants. I first placed a temporary implant because I was not sure of my vertical height of my central implant, and I did not want to compromise that with placing the central implant at the initial stage. And here you can see I took a big piece of the ramus. I took the soft tissue, mobilized that completely so that I could get a closure of my defect and a big bone implant. And then 14 years later, you can see that it's a stable result. It functioned well. And the reason, obviously, is as published in the Science, there was enough buccal bone, at least 2 millimeters of buccal bone to support this implant to have a long-term stable result. And here you can see the 21-year follow-up. The patient did not have a high smile, and so yes, we can obviously better that result with modern technology and modern dental implants and the small soft tissue graft. But for him, 21 years later, he actually came and invited me to his wedding at this stage because he was very satisfied with the result. So if I had a very good professor who taught me, he said, if I say it's good, you don't say better. And I think this, for this patient, was a good result. And now we come to modern day. What do I do today? So this mini implant was placed in a young adult. It was not done by me, it was done by my colleagues, and there's no scientific evidence on this. But for this case, he did not, Maryland Bridge did not work, it was bitten off, and the patient really did not want to have a denture. And you can see on the right-hand side, when I received the patient at the age of 22, he just qualified as a medical doctor. You can see that the previous bone graft did not work. And that was that screw that was left in. So I decided to keep that screw in the apical part because I'm going to use it as a tenting screw. And I did guided surgery. So yes, the surgery digitally planned, absolutely the correct way to go, because with that you can absolutely plan your emergence profile. And I also went and removed that implant. And in 30 years that I've been doing this, and I do many temporary implants, I've yet to see one of those integrate. So I removed it easily, and then I kept my papilla. So I did a flapless technique. And then once the implant was placed, I used bone augmentation. I used half thickness flap, and then mobilized it well, as described now in the literature. So using the literature to my benefit, and used a big soft tissue graft from the pterygoid area. And that is the patient with a temporary restoration, immediately temporized in the soft tissue. And you can see how much I'm keeping the soft tissue graft not from moving apically. And this is the image of the implant in position. Remember that I left the screw in position. I know three-dimensionally that it's in the correct position. And then I give my prosthodontist the opportunity to create an emergence profile for this implant. And this is the result 9 months later. So this is what you really want to see. You want to see a rolled over gingiva, you want to see a three-dimensional profile, and you want to see a happy patient. And that's luckily what we could achieve in this case. So if you have the before and after, you can realize that this is really what science has taught us and where we are going and what results we can achieve after a loss of a canine tooth. And then in another case, if you see, this is a patient of mine, is an adult female, and she was hit with a boat anchor in the mouth. So luckily she took these images, and from these images you can see that there's actually quite a lot of vital tissue in that. And you were asking me about that article in the beginning, what is the right and what is the wrong? So here I think the patient was not treated according to the guidelines that is now available.
So this wasn't you. Did you do the initial treatment then? Did she come and see you?
No, unfortunately not. She
Right.
was in a holiday vacation place quite far, and she saw somebody that did not do regular trauma. Okay. And he just decided to remove everything, but he had heard of bone augmentations, so he augmented it with synthetic bone. And he removed all of those teeth, not splinting any of them. He just removed the upper and lower teeth. So we did a assessment, and in this case, coming back to your question of waiting 18 months, I waited 3 months because that is bone physiology. We removed the acrylic denture because we did not want something to press on this healing process tissues, and we opted for bonded temporary restoration. And luckily I had a very charming patient, and she was also very nice to us, and she posed for these photos. She actually went for a professional photo shoot as well to show us what she looked like at that stage. And the bonded temporary restoration was in position. Why did I do that? Because if you look at that top bit, the coronal buccal part of the alveolar ridge, you can see that that was tissues that I did not trust. So there was no membrane used. There was no techniques of bone augmentation was not accurately used in this case. And I suspected that problem before opening up, because you can see some of the granules coming through here on the soft tissue. So when I opened up, this whole area was not bone. It was just the synthetic material in position. So unfortunately, I could not use that.
So it wasn't a proper scaffold. It was just,
no scaffolding. It was a 3D scaffold for the soft tissue, but it was not bone. And there was, when I used it, it was also not bony element that I could use as an augmentation material. So with a guided analog template, the implants was placed, and then autogenous bone was grafted over this. And obviously, with the autogenous graft, also the soft tissue grafting was done. And you can see how much I had vertically moved the soft tissue, because I knew I was going to have some secondary healing. And this is the result with the temporary restorations then after 12 weeks of healing. And this is our patient still in the temporary prosthesis. So you can see that the premaxilla was starting to remodel in the correct way. And this was our final prosthesis with zirconia abutments in position. And you can see the reason why it kept was the buccal 2 millimeters of bone that was on the implants itself. And the long term, this is the 8-year follow-up of the patient. You can see her with a big smile, and she's confident to smile that way in public. And that is what I wanted. So the time and staging of definitive treatment is first primary stability. And the initial emergence care is obvious and very important. And the time for remodeling. So one thing is be patient, but keep physiology in mind. Definitive treatment can only be done once everything is stable. Extended treatment for pediatric patients, they've got to go through puberty, growth completion, orthodontic surgery or revision surgery that is needed, and then to adulthood. Now, a wonderful article was published by Bonner et al. In 2019, and they from Münster, and they looked at dental implants that was placed in growing patients. They did a review of the literature. They looked at something like 3,500 published articles, of which 162 looked promising, but of all those articles, they could only get 28, which they reviewed. And of those, 490 implants was placed in 147. The interesting thing about this was the patients was between 3 and 18. And the reason for implant placements in such a young group was that it was either ectodermal dysplasia with anodontia or traumatic loss of teeth. And their conclusion was this infraocclusion that I was talking about and dental rotation in the lower mandible. And the conclusion that they did at the end is stating the facts scientifically. They said, if you want to place an implant in a patient below 18, you've got to be absolutely sure of your diagnosis and that you can do revision surgery to the correct level so that you can have an aesthetic result. So in the aesthetic area, and we in our practices is a little bit more conservative. We do not wait until 18, we wait until 21. before we actually do that. And if we get a little bit of coronal advancement of the soft tissue, thus the implant is a little bit shorter than the adjacent tooth, we would keep it rather in that situation than to get a perfect ideal result, which you can publish at say 20 or 21 years of age, because as the patient is going to mature, that papilla will eventually come into its own.
That is a fantastic conclusion to your presentation. But I do see dental reconstruction, dental implants. I think this is the conclusion to your talk. Yeah. We do have a question from Theodore Bourdet. How do you maintain your results over the years? And do you call your patients once a year and remove their crowns?
No, definitely not. I do follow up the patients once a year, and oral hygiene from the science is the most important. So they need to see an oral hygienist often, and then also be controlled by the surgeon. Because what I check three things at every yearly interval. I check the occlusal contacts, if it has changed. I look at the lateral occlusal contacts, if it's opened or not. And if it's opened to such a degree that it's a food impaction or an aesthetic problems, we would address that as soon as possible. And then radiologically, you look at the case as well. And you would do intermediary steps rather sooner than later, before you have a periodontitis, first a mucositis and then a periodontitis. So you would maintain these patients extremely well over the long term, and that is how you get good results. I always say implants in traumatology, it's not plug and play. It's maintenance, maintenance, maintenance.
But I'm assuming, when people do receive care with someone who's been a victim of, of any kind of dental trauma, it's all about, as you said, it's pretty much the first 15 minutes, and you have to be very confident as well. I mean, obviously you have extensive experience, which helps. But I mean, I guess that plays a lot in any kind of decisions that are going to be made at that point as well.
Yeah, and that's why this lecture and that first article by Foud is so important to me, because they stress the time limit. We always know that in general surgery, you've got the golden hour. The first hour after trauma is the golden hour. And the more effective treatment a patient gets in that 1 hour, the better their lifelong expectancy of healing in that wound areas. And in dental traumatology, it's just 15 minutes. So it's even more important. And therefore, we have got to educate the public as well on how to treat evolved teeth.
I completely agree with you with regards to the public being taught as well, because it is so important. And of course, you have such a short time frame, as you just stated, after any kind of traumatic incident. I'm going to thank you very much for your fantastic presentation. It's been extremely informative for me myself as well. I feel very fortunate to, and honoured, of course, to have spent this last hour talking to you. Now, you did actually mention EAO's training programs and such like. Well, there is one called Spring Break. I'm not sure if you're familiar with it. Not the kind of Cancun, Mexico. Maybe the Americans are more familiar with, but one is the second edition in Marbella in Spain. It's 3 days, 9 workshops from the 11th until the 13th of May 2023, so this year. And there is a link below this video, and it's the first 30 places are at a reduced price. So if you haven't already got your places, then hurry up and do so. Well, I think that kind of concludes this fantastic lecture today. Can only leaves me to thank you very much. And maybe just actually, I wanted to mention, you might consider Spain as a Cancun of Europe. No, just mention the work that you have done in Ukraine, because I did see there was one question. I know that you had helped by giving lectures via webcams and such like. So can you just maybe just give a very brief overview of what you actually did there, because it's really fantastic, and I really take this opportunity just to highlight what you actually did do.
One of the dental companies approached me and asked, because there were a lot of dental trauma in the Ukraine at that stage, and their links of referrals were broken down. So suddenly dentists had to treat very severe trauma, and they did not have they needed some guidance on how to treat that. So I was my very first posting as a dentist was in a mobile army surgical hospital during a war situation. And I could help them with the triaging and identifying some of the more severe problems that they should be able to recognize straight off and realize that there was a significant problem underneath a broken tooth. And so I lectured, and whilst I was giving the lecture in Kiev from an online lecture, there were actually bomb raids and going on. So it was a very privileged and significant, not a significant contribution from my side, which I appreciated very much for them asking for the help.
Absolutely, and I'm sure your help was extremely appreciated as well. As I say, well, I can only thank you from my end of things, but thank you for tonight and for all the fantastic charity work that you do as well. We will be back for our next Just Ask at the beginning of March, so please don't hesitate in tuning in the first Monday. I'll see you there. Once again, thank you very much to this evening's guest, Dr. Louwrens Swart. Thank you so much. Have a great evening, and I'll see you in March. Goodbye.